shares. Hello everyone, I am Dr. V Mohan, Chairman and Chief Diabetologist of Dr. Mohan's Diabetes Specialities Center, and I'm making this presentation along with Dr. Rajalakshmi, who has kindly provided me all the slides. Dr. Rajalakshmi is the head of the medical retina at Dr. Mohan's Diabetes Specialty Center and the Madras Diabetes Research Foundation, Chennai. At the outset, I would like to thank the Tamilnadu Ophthalmic Association, TNOA, for requesting me to talk to you. I realize that I am not an ophthalmologist, but a diabetologist, and I'm going to talk to you all about diabetic retinopathy and some solutions. In a sense, it's like carrying coal to Newcastle. However, I have two disclaimers, and that one is that I was married to an ophthalmologist, Dr. V Mohan, who was actually doing only diabetic retinopathy. And so my interest in diabetic retinopathy has been there for more than 45 years now. And we have a whole team of ophthalmologists. Dr. Rajalakshmi is here, and many others are actually listening to this particular webinar. My whole team of retinal specialists, and we kind of practice diabetic retinopathy, so to speak, as the single specialty within the diabetes and eye scenario. Although we do other things, we do cataract and so on, but our main focus both in research as well as in clinical work has been on diabetic retinopathy. And that's the disclaimer that I'd like to make, that I'm not an ophthalmologist, I'm not a retinal specialist, but I'm a diabetes specialist. So also in this talk, I'd like to present some of the work that we have done so that it would be hopefully interesting and novel as far as you are concerned. Let's start at the very beginning and give you an overview of the burden of diabetic retinopathy. We know that diabetes is increasing in our country. About 40 years ago, 2% of urban India had diabetes and 1% of rural India. Today, it's 25% of the metropolitan cities like Chennai, Delhi, etc. And this comes from our own work based on the ICMR INDIAB study, as well as the CURE study, the CUP study, and many other CARS study, and many others, where we have shown that diabetes has now become 1 in 4 of all urban metropolitan cities in India. Now, as you have very high rates of diabetes, its complications also rise, and that will be one of the focus of this presentation. There is also a concomitant increase in prevalence of vision-threatening complications, diabetic retinopathy. Naturally, if you have very large number of people with diabetes, even if a small number of them develop complications like vision-threatening complications, then you have a huge burden of that. And if you actually put this in proper perspective, 90% of the vision loss due to diabetic retinopathy is actually preventable. These are the two sight-threatening forms, as you know, maculopathy or macular edema, and proliferative retinopathy leading to bleeding, vitreous hemorrhage, retinal traction detachment of the retina. These are the causes of visual loss, or what we call as the sight-threatening retinopathy. And what you should understand is that 90% of this is preventable, because by good diabetes control and by keeping your A1C below 7%, and by early screening for diabetic retinopathy, vision loss can definitely be prevented. Now, this is the burden that I was talking about. In the year 2015, these are from the WHO and the International Diabetes Federation IDF figures. In the year 2015, an estimated 400 million people in the world had diabetes, of which, assuming 35% had some form of retinopathy, 145 million people had some form of diabetic retinopathy, and within that, about 45 million had vision-threatening retinopathy. Now, these numbers of 415 million is supposed to escalate by the year 2040 to 642 million. There are some estimates which say 750 million people. Even if you take 642 million, then 224 million of them, assuming the same 35%, will have some form of retinopathy, and this 45 million in 2015 with sight-threatening or vision-threatening retinopathy can increase to 70 million people. Now, 70 million people is actually the population of UK, the population of France, the population of Tamilnadu, and so on. So that's a lot of people to have diabetic vision-threatening retinopathy in the whole world. Now, where are some of these data which come from? I'm sure many of you who are listening in the audience will also have your own data. This is not an epidemiology talk, so I'm not showing all the studies which have been published. I know there have been excellent studies from the Aravind Eye Hospital, both the Aravind Eye Care System, both in the urban as well as rural Tamil Nadu. I know that there have been excellent studies from the LV Prasad, from All India Institute of Medical Sciences, and from many other institutes. What I'm showing here is just two studies. One was an early study which Rema and colleagues did, called the CURE study, the Chennai Urban Rural Epidemiological Study. This is the eye part of the CURE study, a large epidemiological study which is comprising of the whole of Chennai, which was sampled. And in this study, we showed that about 17.8% of the patients had diabetic retinopathy. Believe it or not, almost identical results were obtained from Shankar Nethralaya. This is Rajiv Raman and colleagues from Shankar Nethralaya, who showed that the prevalence of diabetic retinopathy in the Shankar Nethralaya diabetic eye retinopathy and molecular genetic study report, the SN DREAMS as they call it, study was also around 18%. Believe it or not, the same results were obtained from the Aravind Eye Hospital study, as well as from the LV Prasad and almost every other study. Now, I mentioned a figure of 35%. Now, that is what the Western world reports. And in India, this prevalence of 18% has kind of come to stay because 4 independent studies showed the same thing. They all can't be wrong. So the good news is that the prevalence of diabetic retinopathy is actually lower in our population. But the bad news is that we already have 77 million people with diabetes. So even at 18%, that works out to 14 million people in India with diabetic retinopathy. That is 3 times the population of Denmark, just with diabetic retinopathy in India. So the fact that we have a slightly lower prevalence rate should not make us complacent, because every 5th person with diabetes in India can have retinopathy. And these numbers of 77 million is set to increase to 134 million people in the next 20 or 30 years. That means about 30 million people can have diabetic retinopathy in India. Now, one of the problems, I said that 90% of retinopathy can be prevented. Then why are so many people developing retinopathy, and why are so many people developing vision-threatening retinopathy? There are many reasons. The first is lack of awareness among patients that the retina can be affected. Very often, people mistake when you say that you need an eye test, which used to happen in the early days when Rama started her diabetic retinopathy clinic. And we used to say, well, you come for diabetes, you go for your eye checkup. Oh, why should I go for eye checkup? I've come here for diabetic checkup. Then I just changed my glasses last week, so I don't need to do it again. So we used to say, sir, it's not a glasses test, sir, this is diabetic retinopathy. What is that? Then we had to show them the eyeball and say that the cataract and the lens changes and refractive changes come in the front of the eye. This is the back of the eye, the posterior segment we're talking about, and actually show them what the retina was and so on. And it took years for people to understand why a diabetic patient should have an eye test. They used to think simply for making money you're doing it, but that it's part and parcel of diabetes screening. It took years and decades to establish. And that's one of the reasons that they don't do it. And then they'll say, I've come driving, I'll do it next time. And the next time they come will be after 5 years, by the time they're lost with like that. Then there's lack of symptoms like visual disturbances. We say that diabetes is a silent killer. When you get diabetes itself, you don't get symptoms. When you develop any of the complications similarly, you do not get any visual symptoms until it is too late, until you develop the stage of proliferative retinopathy or the sight-threatening retinopathy. And then, as I said, both diabetes and retinopathy can be asymptomatic, and unless advised by the physician, I would say unless persuaded by the physician, the patient may not undertake a retinal examination, a dilated fundus examination or a fundus photograph. I'll just digress a little bit here and say that when Rema and I were in UK, we worked under 2 different bosses who are completely opposite. One was Professor Eva Kona, who used to dilate every patient because she's the kind of guru of, or the queen of diabetic retinopathy. For her, it would be a blasphemy to do a fundus examination without dilatation. So we used to do that, and then we used to take pictures of the retina. The non-mediatic camera had just come. I'm talking about 1984, 85. And then we had another attachment at the Ealing Hospital, where a physician, a diabetologist, Dr. Hugh Mehta, used to see his patients, and he used to always see undilated. Patient will walk in, he'll just have a quick look without look, yeah, it's okay, normal, and he'll go. So when we went there and when we started saying you have to dilate the eyes, he said, no, it's all waste of time. No, you don't do all that. You're just simply complicating matters. I've been doing it for years. So at that time, we got a camera, a non-Midriatic camera, which came, and Eva said you kind of evaluate it at the Ealing Hospital, because a lot of Indians used to come there from Southall. And she believed that the color of the retina itself was a little different because the pigment being different. So she said, you take a lot of pictures there. So when I went to him, he showed me one, and I said, can you send me some patients for looking at the eye? And he said, are you going to dilate? I said, yeah, we're going to dilate. Then reluctantly he gave, and he said, okay, here is one patient whom I have seen last week, and it is normal retina. Now you dilate and see whether there's anything in it. He said, and he referred that patient to us. As luck would have it, when we dilated the eye, the patient had a huge pre-retinal hemorrhage, which he had completely missed because he had seen only the central portion, the disc only he had seen, and he had missed the little away from the periphery it was, little away to the periphery it was, and so he had missed this complete blood clot. That changed the way the Ealing Hospital then thereafter started, looking at the diabetic patient, and every patient thereafterwards started getting their eyes dilated before the fundus examination. I'm just sharing the story with you. It's a true story, just to tell you how even in advanced countries, a dilated fundus examination or a fundus photograph is not done unless the physician cares for it. Now, this is some of the ways in which you can do the screening. You can do it in a physician's clinic. In an ophthalmologist clinic and retinal clinic, it may be different. But in a physician's clinic, you can examine the fundus if the physician himself or herself has the time and the skill and the interest and the ability to dilate the fundus, then the patient and the physician can do it. Many of my fellows in diabetes whom I have trained are excellent in fundus examination because they used to go to the eye department at our center, spend days there, keeping on looking at patients, and they develop the skill. So many of them can do it. A physician can do it. If they can't do it, if they don't have the time, then they should refer to an ophthalmologist for doing the fundus examination. A retinal photography can be done by an eye technician to document the lesions, and sometimes tele-ophthalmology can be done. Today, it's a day of, is the era of tele-ophthalmology, but even before that, I'm sure many of you who are listening to this would have participated in rural telemedicine programs like we were doing, Shankar Netra was doing, Arvind was doing, many others were also doing. These photographs, of course, can be graded either from the van or from a telemedicine unit or from the clinic itself, can be graded either by the retinal specialist, or you can even teach people, even technicians can be taught to grade. In one of the best centers for retinal grading in the world, the Wisconsin Diabetic Retinopathy Center, which Ron Klein and Barbara Klein run, they don't do it themselves. They have taught graduates to do it. They have about 40 graduates who have been trained, and they can do thousands and thousands of pictures. They can actually grade very, very, very accurately. These are only science graduates. They don't have any medical degree of any type. Now, this is some pictures showing in the Chunampet telemedicine van that we have, how the pictures are taken, and then once inside the van, the pictures are taken. We can also do ECG, biotensiometry, everything inside the van. Blood pressure can be checked, A1C can be checked, the weight can be checked. So it's like a virtual diabetes hospital, and this has worked very well in rural areas. So once the pictures are taken, then what we do is then we kind of zoom it back to the ophthalmologist sitting at our center. This is in Gopalapuram, where we have a telemedicine unit. This is Dr. Rajalakshmi doing this, Dr. Pradeepa, and all our ophthalmologists actually take part in the reporting of these pictures. This is one study which we participated in. We had a collaboration with the Emory University and other universities in the US. And one of the things that we did was we compared a non-midriatic camera with a smartphone with a 20 diopter lens with midriaxis with the Zeiss midriatic camera. Now, this is the gold standard, as you know, the Zeiss. But you can see that we can get fairly decent pictures. What we try to see is whether a non-ophthalmologist or a non-technician can get pictures. So you can see that if you actually do it properly, you can get fairly decent pictures. And that was what we reported in the CAMRA study. The CAMRA study stands for Comparison Among Methods of Retinopathy Screening. Now, when the smartphone fundus photography became available, now this is a big salute to the Indian engineers and technicians who were able to reduce the price of the retinal camera. And I know that there's more than one. There are 2, 3 different types of retinal camera compared to the conventional Zeiss camera, which is very expensive, very high quality, but also very expensive. Now, these are very inexpensive cameras made in India, but also have very good quality. So what we did here was, and this can be then used, a smartphone can be attached to this, and then you can capture the picture, and then you can send the picture out to various back to the ophthalmic center or a grading center where they can, and this can be sent by WhatsApp or by email, because from the phone you can send it. You can see all our ophthalmologists here, Dr. Rajalakshmi, Dr. Arul Malar, Dr. Usha, Dr. Prathipa, Dr. Karimuddin. All of them have taken part in this wonderful study, which was published in PLOS One, where we showed that this low-cost camera, actually using a smartphone, compares very well with the gold standard. And I think that is shown in the next slide. No, this slide actually is another one. So there we showed that the sensitivity and the specificity was not too bad. And therefore, even in a low-cost center, you could do that. Now, our center started growing. Initially, we had only our Gopalapuram center, and then we had our Annanagar branch, and then we had our Tambaram branch headed by Dr. Gupta, the Annanagar branch where we had Dr. Muthukumar, Kyle, Vidi. So we have all, we started slowly growing. Then outside Chennai, we started going, and then Dr. Shastri set up the Hyderabad center where Dr. Karimuddin works. So, and within those clusters itself, in Chennai itself, we have 9 centers now, 9 branches now. In Hyderabad, we have 7. In Bangalore, we have 5. So once we started having so many, we cannot have that many ophthalmologists. So what we started doing was, again, using telemedicine, where one ophthalmologist or one center acts as a cluster for all the pictures retinal. So we have retinal cameras in every diabetic branch of ours, every center of ours. But then the pictures are taken by a technician, usually a refractionist, a trained refractionist, who then sends a picture to one of these clusters, either in Hyderabad or Coimbatore or Bangalore, Hyderabad, Chennai. So we have these pictures coming in. Very quickly, the ophthalmologist is able to report on that and send the picture back with the report within a turnaround time of about 20 minutes or so, maximum about half an hour. So while the patient is waiting, the diabetologist gets the report from an ophthalmologist who's trained, and thereby is able to tell the patient whether it's normal, come back next year, or you have mild non-proliferative retinopathy, or moderate or severe, or pre-proliferative, or even proliferative diabetic retinopathy, or sight-threatening retinopathy which needs immediate laser treatment. And I'll show you one case study about that. So this was published by Dr. Pradeepa and Dr. Rajalakshmi, where we looked for, in 2017, 22 branches of our center participated, and about 11,000 people we were able to screen. By 2018, it increased to 25 branches, and we had 14,000. We don't have the updated figures because this is published in 2018-19, but now we have many more branches. We have 48 branches now, and the numbers are much larger than this. But even in this report, you can see 25,000 patients who otherwise would not have had access to diabetic retinopathy screened, and we're able to identify 25% of them who had diabetic retinopathy, and about 2,000 patients who had sight-threatening retinopathy who needed treatment, who could be then referred. And all this was done using a low-cost Remedio fundus on phone camera, and through the images were shared through LAN network. Grading was done by 7 retinal specialists at different centers within the country. So this is a kind of a model which we set up, which I think is quite unique for, at least for a diabetes clinic, it's quite a unique service. Now, the key challenges to widespread diabetic retinopathy screening, remember, if you have 77 million diabetic patients, all those 77 million people have to be screened, not once, but every year. That's a lot of work. and we have only 22,000 ophthalmologists in India. Physicians, still most diabetic clinics don't even have an ophthalmologist, they don't even have a diabetic, they don't even have a retinal camera, okay? And so how do we get this, and how do we get the whole country, every diabetic patient to be screened, okay? Even if after you do this, a trained grader is needed, you have to have so many graders. How do you get in Klein Center? He's the world's US center of excellence for this, so he managed to get 40 graders. How can every center have so many graders and so on? And then if the retinal specialist starts focusing on screening all the time, sitting and seeing pictures, they won't have time to treat. They won't have time to do the surgery. They won't have time to give the injections, intravitreal injections, and so on and so forth. So how can we make better use of this? And that's where artificial intelligence, or AI, comes in as the solution. Now, this is one of the first studies from India where we looked at automated diabetic retinopathy detection, again using smartphone based fundus photography. In this case, we used artificial intelligence to see how accurately it can predict or it can diagnose diabetic retinopathy and the severity of diabetic retinopathy. And then we compared the specificity and the sensitivity of this. And as you can see, we did quite well in this particular study. For any diabetic retinopathy, the sensitivity was almost 96%, specificity was 80%. For sight-threatening retinopathy, it was 99% with 80% specificity. And for referable diabetic retinopathy, these are cases which should be referred to an ophthalmologist, 99.3%. So with artificial intelligence, with the retinal specialist grading as the reference standard, so that was a gold standard, AI is able to predict with almost 100% sensitivity who should be referred. Now, sensitivity is more important. Specificity doesn't matter. If it's the other way around, you miss a lot of cases. That is bad. Here, the sensitivity is very good. You're not missing anyone. But of those who refer, then the ophthalmologist say, no, this case really does not need to be referred. That's better. Actually, that's better, because then you can reassure the patient and then send them off. So I think these techniques are coming to stay. And even in India, all these are possible. That's what the study shows. Now, this is just one example of artificial intelligence and retinopathy real-time and tele-screening. This is a 43-year-old male with type 2 diabetes, 3 years duration. He went to the Tanjavur unit of our center where there is no ophthalmologist. The visual acuity was 6.6 N8, no specific eye complications. He underwent retinal photography using this fundus on phone camera. When the images were sent to our hospital, the images were also uploaded for the AI diagnosis. The diabetologist had the AI-assisted diabetic retinopathy available with him immediately, and this asymptomatic patient was immediately referred for FFA, OCT, and timely laser photocoagulation. So thanks to artificial intelligence tele-ophthalmology, we were able to service this patient. This is just one example of many such patients whom we have picked up. Now, what are the steps to reduce the diabetic retinopathy burden in India? This is a kind of a summary of what we just said. And so you can use the Remedio fundus on phone camera, and then you can use tele-ophthalmology. The consultation can be done through video conferencing, even to remote centers, as we do. Artificial intelligence can be used right on the mobile phone itself. It can tell you in a few seconds whether there is retinopathy or not, and whether it needs to be referred or not. So if you put all this together, then it becomes the artificial intelligence solution or a total package for diabetic retinopathy. And this is an editorial which Dr. Rajalakshmi wrote in the Eye. One more study which I wanted to present to you is that because we are a diabetic center, we know that vitamin D deficiency is very common in India. We also first showed in one study which Dr. Jayashree did, that's part of her PhD thesis. She showed that vitamin D deficiency is more in pre-diabetic patients compared to normals, and even more in people with diabetes. So then we had a student from Emory University who came, who wanted to look at diabetic retinopathy and see whether vitamin D deficiency is more. And of course, lo and behold, we found that vitamin D deficiency is associated with 2 times increased risk for developing proliferative diabetic retinopathy. This is published in Diabetes Research and Clinical Practice. Very recently, Dr. Rajalakshmi and colleagues, this time working with Dr. Shobha Shivaprasad from the UK, we have looked at our data in great detail using a large database. We have a database, as you know, we have the largest electronic records for diabetes in the whole world. We have close to 500,000 patients, 500,000 patients almost now, and followed up for 20 years. And from day one, we had electronic records. So this is by far the world's largest diabetes electronic records. So one of the questions with Dr. Shobha Shivaprasad wanted to do, this is a part of Indo-UK collaborative study called as the ORDINATE study, and Shankar Nethralaya is also part of this. Rajiv Raman is very much part of this. So in this study, we looked at 19,000 patients, and the simple question we asked is, where there is no ophthalmologist, how can a physician predict using biochemical tests who will have proliferative diabetic retinopathy or sight-threatening retinopathy? And it turned out that by looking at the renal function, albuminuria, lowered EGFR, which is as an estimate of the diabetic kidney disease, you are able to predict that people with diabetic kidney disease and or presence of albuminuria had a 5 times higher risk of developing sight-threatening retinopathy. And these are done routinely. Albuminuria and the estimation of EGFR, serum creatinine, these are done routinely in a diabetic clinic. So at least if you don't have a fundus camera, you don't have that kind of facility, at least looking at this, you should be able to say that he has some kidney disease, therefore I should be also affected, and therefore refer the patient. And this is a very important paper just published in the BMJ Open Diabetes Research and Care. We can also look at the feet. If the feet has definite evidence of neuropathy, trophic ulcers, and so on, we can say that this patient probably has a diabetic foot eye syndrome, what we call as. So these are all markers which we use in a diabetic clinic. You don't even have to go that far. Just look at the shin area, and if you see brown spots, what we call as diabetic dermopathy, it's a very good marker of diabetic retinopathy. Finally, there is also what is called as limited joint mobility, or when you put your hands together, it's called as a prayer sign. If you're not able to put them together, but it's like this, it means you have limited joint dysmobility. And such patients, chirioarthropathy we call it, those patients have more of diabetic retinopathy. So these are all markers that we use as a clinician to predict who will have diabetic retinopathy. So this is my last official slide to tell you that it's a kind of summary to say you can protect your vision from damage, from getting damage due to diabetes by what is called this eponym called as TRACK. TRACK stands for take all your medicines regularly, retinal examination annually, add healthy diet and physical activity daily routine, control blood pressure, sugar, and cholesterol, and kicking the smoking habit. So if you're using this TRACK, you can actually prevent diabetic retinopathy. So the most important thing is the world is beautiful. Do not let diabetes prevent you from seeing it. Have your eyes checked periodically. And these kind of messages, these kind of posters, if they are put up in diabetic clinics, also in general ophthalmology clinics, which may not be a retinal clinic, then more and more patients will ask for their eye test. And by this, you can actually prevent diabetic retinopathy. At least you can prevent the sight-threatening retinopathy. This presentation comes to you from Dr. Mohan's Diabetes Specialty Center. This is our headquarters in Gopalapuram. As I said, almost 500,000 or 500,000 diabetic registered patients we have at our center. It's the world's largest electronic record system. We have 48 branches in 8 states of India. These are the states: West Bengal, Odisha, and all the southern states, including Puducherry. And we have currently 130 consultants and 1,400 staff. We have 60 inpatient beds. And these are our contact details. In case any of you want to write to us for further clarification, you can write to us at drmohans@diabetes.ind.in. I also wanted to end with this slide by telling you that I am on social media. I'm a recent entry into this. I thought that we should not lose out the people who use social media to carry correct messages to them. And particularly on YouTube, I have a number of videos which may be of interest to you. They're very short videos, 2 minutes, 3 minutes, to the point. It talks about immunity, talks about vitamin C, talks about vitamin D, talks about COVID, talks about everything that you needed to know. Talks about ambulatory glucose profile, a method of measuring continuous glucose measurements. And so I'm going to stop there and request you to keep in touch with me. I'd also like to thank the Tamilnadu Ophthalmic Association, TNOA, for this opportunity given to me. I'd like to thank Dr. Rajalakshmi for her help with the slides, and thank all our ophthalmologists for the great work that they have been doing in making a diabetic center a retinal unit as well. It's a unique example, and I pay a rich tribute to my late wife, Dr. V Mohan, who set up all this and trained most of the ophthalmologists who work with us. I'd also like to thank all our diabetologists who do such a great work. Finally, I wish all of you happy times and healthy times as we go through COVID. Remember that COVID only affects a very, very small percentage of the population. And my message is to tell you that you are very, very, very unlikely to get COVID. You are almost impossible that you are going to die due to COVID. So remove the COVID fear, remove the COVID, the paranoia that you may have, or the fear that you have, and stay healthy, look after your patients, and I wish you all the best. Thank you very much.